Namaste Betiya, Hamisha Khush Raho Betiya. A very good morning to you all. Myself, JVN Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about the various disorders of the sodium metabolism. Sodium is an important element or mineral for us, and there are a lot of disorders that you are going to see when this particular metabolism is disturbed. So today we are going to discuss about each one of them. This is an important topic from the examination point of view because many times you get a short note on this particular topic. Now, as we all know, and you must have studied in your first year physiology classes, physiology and biochemistry, how the metabolism of sodium, chloride, potassium, and other minerals takes place through the cell membrane. So let us try to understand the metabolism of sodium in the body. And before that we are just going to revise about the normal physiological content in the body. So what is ECF, what is ICF, all these things we are going to discuss first in this particular lecture. So let's start with this topic. A lot of things you have already studied in your first year, the physiology and biochemistry. So first of all, we are going to revise those things, and then we will be starting with the sodium metabolism. Now, as we all know that water content in the body is around 60%. And the fat content is contains less water. Obese have less body water because in the case of obesity, the fat content is increased. So obese patients have less body water, and the water in the body is distributed in two major compartments. So whatever water is available in the body, it is distributed in majorly two compartments. We have intracellular fluid, ICF, and extracellular fluid. The intracellular fluid consists of around 66% of the body weight, and extracellular fluid is around 34% of the total body weight. The extracellular fluid is again divided into three parts. We have interstitial fluid, we have intravascular fluid, and we have transcellular fluid. So the extracellular fluid is further divided into three parts: interstitial fluid, intravascular fluid, and the transcellular fluid. The interstitial fluid is around 65%, the intravascular fluid is around 25%, and the transcellular fluid is around 10% of the body weight. In the intravascular compartment, only 10% of the water is seen as in the arterial system, and 55% in the capillary system, and 35% remains in the venous system. So this is the distribution, and I will again repeat this body fluid distribution. I have also given multiple e-notes on the portal that shows all this distribution. So you can go through the e-notes and you can learn about all these things. So the body fluid distribution in two distinct areas. We have intracellular fluid, ICF, that contains around 40% of the body weight. And next we have extracellular fluid that contains around 20% of the body weight. The interstitial fluid is 15% of the body weight with 5% of the plasma weight. Now, what is the difference between the ECF and the ICF? The extracellular fluid remains outside the cell, while the intracellular fluid remains inside the cell. The protein content in extracellular fluid is less, whereas the protein content in intracellular fluid is comparatively more. The major cation in case of extracellular fluid is the sodium, mainly with potassium and calcium, whereas in the intracellular fluid, the major cation is potassium with some quantity of magnesium. The major anion in case of extracellular fluid is chloride, whereas in the intracellular fluid, it is phosphate. So in the extracellular fluid, we have sodium and chloride, whereas in the intracellular fluid, we have potassium and phosphate. Now, there are a lot of biochemistry investigations we are doing in the patients. Why we are doing such investigation and what is the significance of such investigations? Biochemical lab investigations are required to screen an asymptomatic patient. Suppose an asymptomatic patient is coming to you, and then you have to screen out the abnormality that is going to happen in that particular patient. Then in such case, biochemistry lab investigation is done. And for the diagnosis of patient presenting complaints and to monitor the changes in the test result as a marker of disease progression or respond to the treatment. So biochemical lab investigations are required to screen out the asymptomatic subjects, to assign the diagnosis of the patient presenting complaint, and to monitor the changes in the results as a marker of disease progression or response to the treatment. Now we come to the sodium metabolism. Now, sodium in the sodium metabolism, the normal plasma, as we have understood that in the extracellular fluid, the major cation is the sodium. So the normal plasma concentration of sodium is between 135 to 145 millimole per liter. So the normal plasma concentration of sodium, it is around 135 to 145 millimole per liter. And the main determinants of the sodium metabolism includes the water intake that has thirst or habit. It depends on the thirst, how much the patient is thirsty and what is the habit of the particular patient. It is non-sensible. There are certain non-sensible losses, which includes the sweat and the urine. So with the sweat and the urine, there are some losses of the sodium that takes place. There are some non-sensible losses, which includes the sweat and the urine. So in the normal, in the sodium metabolism, the normal plasma concentration is around 135 to 145 millimole per liter. The main determinants of the sodium metabolism or the sodium concentration includes the water intake that depends on the thirst and the habit, and non-sensible losses that includes the sweat and the urine, and also hormone arginine vasopressin that determines its presence in the body. Now, there are two different types of disorders that are related to the sodium metabolism that we can see in this particular type of disease. One, we have the sodium excess that is known as the hypernatremia. And the other condition is the sodium deficiency that is known as hyponatremia. So there are two types of disorders in the sodium metabolism. We have hypernatremia and we have hyponatremia. When the concentration exceeds 145 millimole per liter, then it is known as hypernatremia. And when it is below the normal level, it is known as the hyponatremia. Now, what happens in the sodium excess? That is in the case of hypernatremia. Sodium excess or hypernatremia is a common electrolyte problem, and it is defined as the rise in serum sodium concentration. So whenever there is rise in the serum sodium concentration to the value exceeding greater than 145 millimole per liter. So in hypernatremia, we have sodium levels, the serum sodium concentration that is more than 145 millimole per liter. There is hypernatremia that is caused due to number of factors. So number of factors are responsible for the development of hypernatremia, and these are classified on the basis of clinical conditions pertaining to the volume of water in the body. So hypernatremia, it is caused due to the number of factors, and these are classified on the basis of clinical condition. These are pertaining to the volume of water in the body. Now in the classification, we have hypovolemia, hypervolemia, and euvolemia. So sodium excess can lead to the development to the three conditions. It can result into hypovolemia, it can result into hypervolemia, and it can result into euvolemia. Now, hypovolemia. What is hypovolemia? When the volume of blood or the fluid is decreased in the body. What are the different conditions in which we can get hypovolemia or decreased volume of water in the body? When there is dermal losses. Dermal losses means losses through the skin. This can be seen in case of burns and sweating. Second condition is when we have gastrointestinal losses. Gastrointestinal losses are seen in the diarrhea and vomiting. The third variety is when you are being prescribed diuretics that induces urine. The fourth variety is the acute and chronic renal diseases. And fifth is the hyperosmolar non-ketotic coma. So we have hypovolemia that is seen with the dermal losses with burn and sweating. There are different types of gastrointestinal losses, which includes diarrhea and vomiting. Different diuretics. We have acute and chronic renal diseases and hyperosmolar or non-ketotic coma. Second is the condition of hypervolemia. Hypervolemia, when the volume of water is increased in the body. It can be iatrogenic. Iatrogenic means when it is associated with the treatment, hospital treatment. When there are the condition of excessive hypertonic saline administration, when there is tubal feeding or hypertonic dialysis. So hypervolemia can be seen in case of iatrogenic diseases that are associated with the hospitals. That includes hypertonic saline, we have tubal feeding, we have hypertonic dialysis, etc. And the second condition is the hyperaldosteronism. In this condition also, there is excessive sodium leading to the hypervolemia. The third condition is euvolemia. Euvolemia means when the volume remains normal or within the normal range, but still we have some symptoms. It occurs in diabetes insipidus. Second is hypodipsia. Hypodipsia means when there is reduced thirst. Third is the fever, and fourth is the hyperventilation. So euvolemia is seen in 4 different type of conditions. We have diabetes insipidus, we have hypovolemia, hypodipsia, we have fever, and we have hyperventilation. Next, we come to the clinical features of hypernatremia. What are the different clinical features of hypernatremia? Whenever a patient of hypernatremia is coming to us, what are the clinical features? The clinical features of hypernatremia or the sodium excess includes the peripheral and pulmonary edema. So if there is excessive sodium in the body, then there will be peripheral and pulmonary edema that will be seen with pleural effusion and ascites. So we have peripheral edema, we have pleural effusion, and we have ascites. Next, we have the systemic hypertension. Why there is systemic hypertension? Because in the ECF volume, it causes hypervolemia. Because of the increased sodium, there is more retention of water that will produce hypervolemia, and there will be systemic hypertension. It occurs in the primary aldosteronism and acute glomerulonephritis. So we have already, we are going to study acute glomerulonephritis in the final year. So hypervolemia, it occurs in the primary aldosteronism. So in case of primary aldosteronism, we are getting hypervolemia and acute glomerulonephritis. There is also edema with the signs of hypovolemia. So there can be edema with hypovolemia. There will be postural hypotension, poor peripheral circulation, and oliguria, and it occurs in case of hypoalbuminic states. So we have edema with the signs of hypovolemia, we have postural hypotensions, poor peripheral circulations, and oliguria, and it occurs in the hypoalbuminic states. Now, what are the investigations that could be done in case of hypernatremia? So as the sodium level is increased, so we have to check for the plasma sodium level. It is usually normal, or it may be low if water is retained. It is raised, the sodium level is raised in the primary hyperaldosteronism. Now, how to manage a case of hypernatremia? If the condition is of hypernatremia, that is the sodium level greater than 145, then we have to manage it by using diuretics, because there is a lot of water retention in the body. So we have to prescribe diuretics. Next, we can give plasma protein infusion if hypovolemia is life-threatening. So if the water cannot be drained out, then we have to give the plasma protein infusions. Aldosterone antagonist have to be given in case of Conn syndrome. And hemo or peritoneal dialysis can be done if there is inadequate response to the diuretic therapy. So this was all about hypernatremia. Now we come to the sodium deficiency, that is known as the hyponatremia. Hyponatremia, when the sodium concentration in the blood goes below the normal, that is below 135. Now, this occurs in the following condition. Hyponatremia is it is a low sodium concentration. So hyponatremia is basically the low sodium concentration in the blood. And it is generally defined when the sodium concentration goes below 135 millimole per liter. And the symptoms can be either absent, it can be mild, or it can be very severe, depending upon the level of the sodium. Now, what are the different causes of hyponatremia? Hyponatremia can be seen in case of excessive sweating. Whenever there is excessive sweating, then you can see hyponatremia. When there is GI fluid loss, whenever there is fluid loss in the gastrointestinal tract, that is seen in case of diarrhea and vomiting. Excessive renal loss, that can be seen in mineralocorticoid deficiency, Addison's disease, or hypoaldosteronism. There is also renal salt wasting that is seen in chronic pyelonephritis, renal calculus, analgesic nephropathy. Hyponatremia can also be seen with diabetes mellitus or excessive diuretic therapy. In the condition with excessive ultrafiltration by hemo or peritoneal dialysis, this can result into hyponatremia. If there is more and more dialysis, then it can also result in the development of hyponatremia. So the causes of hyponatremia includes excessive sweating, excessive GI losses, that includes diarrhea and vomiting, excessive renal losses with mineralocorticoid deficiency, Addison's disease, or hypoaldosteronism, renal wasting, salt wasting, that includes chronic pyelonephritis, renal calculus, analgesic nephropathy. It is also seen with the cases of diabetes mellitus with excessive diuretic therapy and ultrafiltration by hemo or peritoneal dialysis. Now, what are the clinical features in the case of hyponatremia? In case of hyponatremia, there will be sunken eyes. So eyes will be sunken and the cheeks will be sunken. There will be weakness. The patient will complain of weakness, fainting on standing. There will be muscular cramps in the legs. The patient will be thirsty with cold hands and feet. The skin is inelastic and with low intraocular pressure. There will be tachycardia and the weak pulse. The patient also complains of postural hypotension, and there will be ultimately circulatory collapse or death. So the clinical features of hyponatremia includes sunken eyes and cheeks. We have weakness, fainting on standing. There is muscular cramps in the legs. We have thirst, cold hands and feet. There is skin, it becomes inelastic and with low intraocular pressure. There will be tachycardia with low pulse, postural hypotension, and ultimately there is circulatory collapse and death of the patient. Now, what are the investigations? In the investigation, the plasma sodium concentration may be low or normal. There is raised plasma urea creatinine level because of the impaired renal function, and there can be fluid input-output chart. Daily weighing of the patient has to be maintained. So investigation, normal plasma sodium concentration level, low or normal, raised level of plasma, urea and creatinine level, and fluid input-output chart, and daily weighing of the patient has to be done. Now, how to manage such cases? In the management, acute hyponatremia carries a risk of cerebral edema. So we have to restrict the fluid to less than 1 liter per day is the initial approach. We have to give demiclocycline is the drug of choice, and aquaretics induce water diuresis without affecting the urinary electrolyte or solute excretion. So this can be done. So we can acute hyponatremia. It produces a risk of cerebral edema. So fluid restriction less than 1 liter per day is done. Demiclocycline is a drug of choice, and aquaretics can be given. So this was all about the sodium metabolism. In the next lecture, we are going to discuss about the potassium metabolic disorders. So this session is powered by digital version 2.0, JAYOTI VIDYAPEETH Women's University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.